Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Welcome back to another episode of Dental Implant Practices podcast. I'm your host, Philip Gordon, and it's my special pleasure to introduce our guest today, Dr. Dickinson Goodchild, DMD. He is an associate professor at the Department of Diagnostic Sciences at Creighton University School of Dentistry. Jason, how are you doing tonight?
I'm well, Philip. Thank you for having me.
Okay, well, it's my pleasure to be talking to you. I know Dr. Garg, recommended that I call you, and he had great things to say about you and said you are the go-to guy for dental pharmacology as it relates to dentistry and also oral surgery and implant dentistry. So I wanted to reach out and see if we could talk about some medicine as it relates to dentistry here. So why don't you give me a little brief introduction of yourself from what you do in your teaching at the university, what you do in your private practice, what you're doing with Dentsply Sirona, and what you're maybe doing with other teaching that you're doing.
Currently, I am Associate Professor and Chairman of Diagnostic Sciences, Department of Diagnostic Sciences at Creighton School of Dentistry. So I oversee a varied department. We go over things like treatment planning, soft skills, assessment of dental patients, treatment of medically complex patients. Also includes things like radiology, the curriculum for radiology, and the curriculum for pathology. So kind of a varied or wide scope within that department. That's a real challenge, and I'm really enjoying that. I have a private practice outside of the city of Philadelphia in Havertown, Pennsylvania, family practice, a long-standing general practice started not by me. I'm the third dentist there, but it originated in the 1950s, so kind of a long-standing practice outside of the city. And then lastly, my actual full-time job, last one is with Dentsply Sirona. I am a clinical education manager for North America in the restorative division. So what that means is that I'm really involved in the continuing education, not only of the reps that would visit your office, but also dentists around the country that could be using those products. And those products, what I mean by that is from the restorative division would be things like, bonding agents and composites and impression materials. How to use those products better, how to understand kind of the new features that they're trying to introduce into those products, and then how to get the most out of it for your patients. So in that way, education really has been a huge part of my career over the past few years, not only at the academic side of things, but on the industry side of things. And then to cap it off, with all that the free time that leaves, I do continuing education courses. Not only in the United States, but I've had the pleasure to speak to dentists around the world, actually, on topics things like pharmacology or treatment of medically complex patients, and then sedation and nitrous oxide, and then of course the restorative dentistry pieces that I just mentioned, things like composites and impression materials and stuff like that. So it's an interesting time right now, and I'm glad to be helping dentists do things better if they can.
Well, that's quite an impressive lineup and resume, and I'll tell you, I just do one of those things. I just practice dentistry, and that keeps me more than busy, so I can't imagine. You see the full circle, kind of. You see the teaching at the institute, you have a private practice, you teach other dentists, and you teach reps. So, you kind of see all angles of dentistry as it relates to the whole scope of things. So I think, that's got to make you very well-rounded. And I know that's probably been quite a journey throughout your years. That didn't just all happen over one night. I'm sure that was quite a progression of things.
Yeah, that's an interesting thing to think about, how to craft the message to each of those individuals, the dental student to the practicing dentist that may have many years of experience, and then to a field service representative. And the idea of dumbing things down, I don't think is the right way to approach it. It's just a different message. You're trying to communicate the similar things and put it in terms that people can then ingest, process, and then hopefully use to really help their patients or their clients. So it's really about understanding who you're talking to and trying to give them whatever they need to get to move forward.
Yeah, that's great. I would love to dabble in some of those departments, but right now I'm just trying to keep my head above water in a private practice. So maybe one day I'll branch out there. But
yeah, it feels that way too for me as well. I think it really, it's people say, how do you do it? And with all the travel and so forth. And I just have to credit that I have a very tolerant wife and an understanding family that let me do these things because it's a passion and I enjoy it.
That's great. You've got to have a good support team, and that definitely starts at home. You've got to have a very understanding family, and then you got to have a great support team in every aspect of your adventures. So that's great. So, tell me about how you got started in implant surgery or oral surgery. I know you are a practice dentist. So, are you placing many implants? Do you have much involvement with restoring implants in your private practice? What are you doing in your own private practice?
Yeah, so it's a family practice, and I do sort of pick and choose the ones I want to do, the implant placements I want to do, and I keep them fairly simple for my office. I tend to work with specialists. I love the specialty involvement, the collegial relationship between the specialists in my area. And what I really do enjoy, though, is the restoration piece. So I do the simple placements, but I really enjoy the restoration side of things. And where this all began, actually, it was, I graduated from University of Pennsylvania Dental School and had an opportunity to do some additional oral medicine training under some really great faculty members. And I believe a lot of this starts with good mentoring. Gentlemen like Martin Greenberg or Michael Glick, some of those bigwigs in oral medicine, helped me to really appreciate that relationship between medicine and dentistry and understand some of the pharmacology that goes along with it. How can we just take what we're already doing and maybe do it a little bit better by what I like to call knowing your rights, the right patient, right procedure, right drug, right equipment, all that stuff put together can really equal some nice outcomes. So why not use all those things at your disposal? The idea of right antibiotics, right anti-inflammatories, right analgesics, putting that in together with some really nice technology that goes along with implants, from not only from the equipment for placement, but the imaging side of things too. And really what you got is a real recipe for success. So I've enjoyed that. And the pharmacology piece has been one that I've really tried to focus on.
That's fantastic. I know, like you're saying, being very comprehensive and thorough in your approach and thinking more of a, oral medicine doctor, not just a tooth driller. And that's definitely important. So, I'm going to start off with some real open-ended, vague questions because I don't even know what to ask you other than kind of start walking me through pharmacology as it relates to oral surgery and implants. When you graduate school, I feel like you're lost in pharmacology. They don't tell you much about it. It all seems very complex. They tell you, keep it minimal and keep it easy for the patients and give them the cheapest drugs and try to dumb it down for the dentist and the patient. But I know that that's not necessarily the right approach as I've practiced for 7 or 8 years. But tell me, as it relates to oral surgery and implants, start walking through somebody what good ideas are, what bad ideas are, just kind of start building a platform, what people should be doing more of.
Well, I think it starts with knowing your patient, understanding, what level of medical complexity they are. Studies will suggest that about 1/3 of all patients that walk into your office are medically complex, meaning they may have a systemic disease that will be managed with some sort of pharmacotherapy. So understanding that and then trying to stay away from pitfalls like drug interactions or procedures on patients that may be a little less stable. I think that kind of really insulates you and increases your safety. From there on, I think that there really are 3 drug classes that every dentist just got to know backwards and forwards. And that really is around local anesthetics, first and foremost, and then the idea of antibiotics, and then finally analgesics. And then lately, I've actually added a 4th drug classification. That would be anti-inflammatories, and we can go into that a little bit if you'd like to. But just knowing the basics of those 3, maybe 4 categories can really make a huge difference because, even though dentists can prescribe anything in the U.S. pharmacopoeia, our scope is very limited. You know what I mean? We really only are focusing on kind of those 3 categories. And knowing those, sticking within those, it can make a big difference. And again, knowing your rights, the right patient, the right drug, right procedure, kind of putting those things together, like I said, can really help you. So for me, I always start with local anesthetics. The idea of is lidocaine our go-to? Where does articaine fit in? Do we need longer-acting local anesthetics? And then there's bupivacaine. How to really maximize efficiency when it comes to local anesthesia, getting it right the first time, having it be effective for the procedure, and then utilizing local anesthesia as a primary pain control mechanism post-operatively is a wonderful idea. And a lot of dental state boards are echoing that sentiment because opioid abuse is a big topic right now. And, the state that I practice in, Pennsylvania, actually has some guidelines for dentists in Pennsylvania that say that first line pain control should be really around local anesthesia, and then bringing in things like ibuprofen and Tylenol, and then minimizing the narcotic or opioid analgesics as much as possible. So really, local anesthesia has a wonderful place here. And then, just getting back to basics with your technique and understanding, half-life and how long these drugs last and how much we can give. I mean, you'd be surprised. I think that the dentists that I speak to sort of eat that stuff up. That we get used to doing what we're doing. But boy, if you can open my eyes to a new way to think about local anesthesia, we would really like to hear that, because we're good at it. I mean, that's our thing. And then you get into things like antibiotics. Antibiotics, some people would say that we probably overprescribe, not dentists, but just in medical professionals, dental professionals in general. And that may be true, but when you relate it to specifically implant surgery, there's a lot of good research around antibiotic use. The idea of preoperative chlorhexidine rinses and antimicrobial around the time of placement. And then there's this idea around, should we be prescribing preoperative antibiotics before implants are placed? And depending on who you read, Dr. Garg, Dr. Mish, certain individuals, they may have their own little recipes. But, there's actually some good research from the Cochrane database, meta-analyses around the use of antibiotics and what we should do preoperatively. Should it be augmentin, or should it be doses before and after surgery? But the truth is that, the best available evidence, even in the 2013 edition of the Cochrane database, says that 2 grams of amoxicillin given 1 hour before implant placement is your best option. And we still don't know if antibiotics given post-operatively have any effect and what that dose should be. So, the idea of the old 2 grams of mox before you start implant surgery is still best medicine and best practice. I think that, again, minimizing exposure to antibiotics is a big piece here, and keeping it simple. So 2 grams. And then the analgesic piece, after the fact, how do you treat these patients if you're going to do, open flap surgeries, bone graft procedures, and invasive things? Even evidence now is still suggesting that ibuprofen-like drugs, non-steroidal anti-inflammatory drugs, may have a primary role, a first-line role in even those complicated surgeries. Then the idea of maybe even combining them with acetaminophen to have a kind of a cocktail, like a 2 or 3 ibuprofen, so that would be 400 to 600 milligrams, together with 500 to 1,000 milligrams of Tylenol, given every 6 hours, might be more successful than some of the narcotic regimens that we've been using over the course of our careers. So those 3 really, I think, kind of is a great place to start. If you can get those basics right, you've probably captured, I want to say, maybe 90% of the patients. The other 5 to 10% are those outliers that may require a slightly different approach, but certainly the basics cover the most of those patients.
Well, I think that's great. You definitely covered a lot of information there. Let me break this down even simpler for our callers, our listeners, and myself. So let me give you 2 scenarios. A basic extraction, bone graft, socket preservation in number 14, or a basic tissue reflecting implant placement number 14, either procedure. What I do is give 1 carp articaine, maybe 1.5 carps articaine, do my procedure. So actually, let me back this up. I have the patient in, I give him 2 grams of amoxicillin pre-operatively in the office. So we give that to them, they take it. I give them 1 mouthful of chlorhexidine. They swish with that for 30 seconds and spit it out. Then I numb my patient up with about 1.5 carps of articaine, and then I have them do a second mouth rinse of chlorhexidine. We do that oral surgery or implant placement procedure Then I do a final mouth rinse of chlorhexidine before they leave the third mouth rinse of chlorhexidine before they leave the office. Then I prescribe them, typically if it's a normal patient with no allergies, I give them more of the amoxicillin. I do 500 milligrams 3 times a day for a week, so 21 tabs. They leave with a prescription for chlorhexidine, swish and spit 2 to 3 times a day for 2 weeks, and they leave with Norco pain medicine, as needed for the first couple days, and then I tell them to take 600 milligrams ibuprofen with 2 extra strength Tylenol during the daytime while they've got to be at work and can't take the Norco. So tell me if you like all of that, if you think that's good, if that kind of fits in line with what you were saying, if you think that should be tweaked a little bit. Kind of talk me through what that's typically what I do. What do you see? What flaws in that do you see? Where do you think I can improve, or where do you think that should go moving forward?
I think what you're doing sounds great, and I think that the majority of your prescribing or approach is based off of you want to do the right thing for your patient. You want to treat them well. You want to make sure that they're comfortable. I mean, this is all about a patient experience, and you want to create a patient experience where they say, well, that wasn't so bad. The doctor really had control of it and managed it. And so there's really nothing bad to say. Could I tweak it? Maybe, because like I said, the most current research to date says you don't need amoxicillin post-operatively. Now, there's caveats there. Like, if it's a healthy site on number 14, then 2 grams of amoxicillin is probably fine. If you think you're close to the sinus, or, maybe you nicked something, or, maybe you add in a slightly different version of amoxicillin called Augmentin, or amoxicillin with clavulanic acid, which may be a little bit more effective when you're dealing with around the sinuses. Or maybe they're allergic to penicillin, so you want to maybe give clindamycin. Then there's other ones too. There's other antibiotics that you could consider.
Typically, I do amoxicillin. If there's more involvement with a little more infection, maybe I do Augmentin. And if they're allergic to amoxicillin, maybe I do clindamycin. But yeah, I think you nailed it there. So I mean, that's 95% of what I prescribe right there. And I think I'm speaking for other dentists here too, but maybe I'm wrong. I don't know.
Yeah, no, I think you're right. I think what most people feel like that's my algorithm, right? If I start with amox, if that doesn't work, I'll go to clindamycin. And if it rips up their stomach, then maybe I'll think about azithromycin. But don't forget that there's Cipro in here to consider for certain types of patients. Levaquin maybe have a role. I mean, so you could tweak these things, but I think again, what I said earlier about knowing where your guardrails are, potentially staying in a small scope of prescribing is probably your best option. And those 3 drugs probably get you what you need. But like I said, I don't know if you need the post-operative antibiotics, and I know that's born out of trying to do the right thing and prevent post-op problems, but you might not need that. That's the problem with these kinds of discussions. I feel like, Philip, is that everybody has their own little recipe, and what's working for you. Some people will say, well, it's working for me, so why should I change? And I don't have a great answer there, other than to kind of fall back on these kind of large studies that say that we just don't know what the answer is for post-operative antibiotics in healthy sites. In slightly less healthy sites, maybe there's a role there. I love what you're doing with chlorhexidine, no question about it. I think that's a wonderful adjunct. And some authors would even say, you start maybe a few days or a week before and go a week after too. So there's maybe some things there. I've even heard in some publications around implant surgeries and minimizing or maintaining more of an aseptic technique is, covering the patient's face, covering drapes, covering the patient's nose with a nose crib or something like that to prevent any kind of a touching of the nostrils, because they can have bacterial infection in the nostrils, things like that. So there's a variety of ways to stay clean during the surgery, drapes, sterile gloves, that sort of thing. Chlorhexidine is wonderful. And then I do like the idea of providing adequate pain control for your patient, because I think the best thing you can do is kind of anticipate level of pain and try to prescribe accordingly. The only thing I would say is that do you really feel like you need it, or do patients really expect it with the Norco? It's the idea of, when you do a simple extraction of tooth number 14, are you always prescribing a narcotic? And some people would say, yes, I am. Others may say, no, I haven't prescribed narcotics in a while, because some patient populations are different. Some cultures of the office are different in that, maybe practitioners don't want to get post-operative phone calls, so they almost over-prescribe, trying to prevent that or giving the patient more control of their pain level. But then also falling back on this idea of that, pain in dentistry is really an inflammatory process. And so narcotics, even shotgun preparations like that hydrocodone and acetaminophen, they will do nothing for inflammation. They're just trying to, specifically narcotic, will just sort of cloud your sensation of pain. They're not that fantastic for dental pain. That's where the ibuprofen or the nonsteroidal anti-inflammatory drugs come in. So utilizing those might, as a first line, maybe kind of the way to go, and then breakthrough pain, maybe have to manage with narcotics. But I often think that this is unfortunately a cultural thing, not only with patients but with dentists. Dentist side of things, this is what we've always done. We haven't had any problems, so that's what we're going to do. From the patient side of things, they're thinking, well, wow, this is a really invasive surgery, so I need to step up to the best pain med, which would be a narcotic like Percocet or Norco. And you know what? The research doesn't really show that to be true. It consistently shows that those NSAIDs are equally, if not better, than the narcotics for post-op pain. And again, this maybe is this whole overarching theme around analgesia, is that we have less tolerant patients. Patients don't want to be in pain. For patients to accept treatment, in a lot of cases, they have to be almost assured that we will provide them with something to take care of their pain. So this is a very complex issue. And then it kind of feeds into this last piece, though, that I keep talking, maybe this fourth category, which is anti-inflammatories. So let me ask you a question. Have you ever considered using a corticosteroid like dexamethasone post-operatively for your implant surgeries?
Well, until recently I hadn't, but I'll tell you, I'm starting to think more and more that's the ticket. But early in my career, I've got to be honest with you, I was very maybe ignorant in that category. But the more that I do and the more that I see, I'm with your thinking, it's more about inflammation than it is pain control. Because most of the things I do, if done correctly, most patients say I had little pain. And the real problems that I run into, and when I say problems, not even really major problems, but short-term hiccups are more based around inflammation, swelling, those kind of things. So I would love to pick your brain about the anti-inflammatories, because I think that's more problematic than just I can't get the pain under control. I think that's less the issue. More and more that I've refined my processes and gotten great at my surgical techniques, I'm running into more of how can we control people's anti-inflammatory, their inflammation responses. And so I've got to be honest with you, I don't know as much as I should about that. And that's one major thing I wanted to talk to you about. How could I incorporate that? And if I do, what is that? I mean, am I injecting it? Is it an oral dose? What's out there and what are people doing?
Yeah, it's for me, and you'd mentioned some things about oral surgery, and let's factor in endodontic therapy here as well, because I think there could be a role around anti-inflammatories in all three of those things, for the implant side of things, the oral surgery side of things, and then for the endodontic side of things as well. So when I started looking at this issue a few years ago, the idea of integrating a glucocorticoid like dexamethasone into my regimen, not only for implant placements, but again for oral surgery or even routine endo, I wanted to know a couple of things. One, was it going to impair healing? Would steroids, give me a delayed healing response or some way impair that for the patient? And, the short answer to that is really no. Patients taking chronic steroids perhaps, but at the doses that I was coming up with, and again, this was around dexamethasone and the dose was really somewhere between 4 and 8 milligrams. The answer was no. And there's some good studies to suggest that wound healing will not be delayed. You won't see problems with healing when you keep those doses low and maybe 1 or 2 doses at most. Then, I thought to myself, well, all right, is there going to be a problem if I use glucocorticoids like dexamethasone, and how will it impact my osseointegration of implants? Will that, that the idea that I first thought of, which was the idea of healing, could it also impact osseointegration of implants? And again, there's some really good studies around this where they would do implants into rabbits being treated with long-term steroids, high dose steroids, and then try to look at osseointegration of those implants over time. And they all show wonderful results that, short term, and even some more long-term use of glucocorticoids does not impact the osseointegration of dental implants. So I thought, wow, that's good. So I'm not worried about healing. I'm not worried about osseointegration. But in the long run, what can they do for me? What is the benefit, or why should I consider those glucocorticoids? And it's mainly three things, right? So when you think about surgery, not only oral surgery but implants, you might be thinking about just overall pain levels, swelling of the area, and then finally trismus. In certain areas, maybe even for third molar extractions, would see some trismus. And glucocorticoids, actually, there's, again, good research to show that they'll help at all three of those things. That pain within at least the first 24 to 48 hours could be reduced by 50% just from one dose of glucocorticoid. And that'd be 4 milligrams of dexamethasone. So just that one thing alone was like, wow, that really opens my eyes. And then the idea of swelling and trismus, again, almost a 50% reduction within that 24 to 48 hours. And so I was sold on that idea. And so then it comes to the idea, well, how should we use these things? You can write prescriptions for a 4 milligram tablet of dexamethasone to be taken on the day of surgery, the day before surgery, the day after, so right around the time of surgery. And studies have shown that if you give a 4 milligram tablet of dexamethasone, it will last about 2.5 days. So it's not critical that you give it 1 hour before or 1 hour after, because you've got like 2.5 days of effect from that one dose of medication. So pills are good. And, even there are metered dose prescriptions, things like Medrol dose packs you can give. They even have Dex packs, with their dexamethasone packs, which is like, it's like pills on a card that you pop out and give one per day for 14 days or 10 days. All that stuff exists, but, just that one pill can get you 2.5 days or more of pain, swelling, and trismus relief. And I said, well, all right, well, that's good. But, that means I either have to buy dexamethasone in my practice or I have to write a prescription. And, every time you write a prescription, probably half those prescriptions don't get filled. So I said, well, how can we make this even better? And then, I said, well, let's start injecting it. And in the research around this, around submucosal or subperiosteal injection of dexamethasone for surgery or implant placements, there's a lot of it. And so a couple of things. One, it's easy. It's super easy and it's super cheap. And the best part, perhaps, is that even though those pills, they give you 2.5 days, one pill, 2.5 days approximate duration of action for those, but just by injecting it, you get up to 6 days. So you get 6 days of pain, swelling, and trismus relief from just one simple 4 milligram injection at the time of surgery, implants, endos, implant placements. So for me, that was a no-brainer. How do you do it? Well, again, 4 milligrams, I think, is the target dose for dexamethasone. There's a lot of research around that particular drug. There are other drugs like Medrol, methylprednisolone. Everybody's heard of it. But, that one dose of dexamethasone is all you really need. And it's super cheap. But you can get a vial of 4 milligram per milliliter dexamethasone, a 5 ml vial, for around $3. And again, so that would be 5 doses for around $3. And then what you do is you get yourself some tuberculin syringes. You can get 1 cc tuberculin syringes. They're 29 gauge, half-inch needles. You might be able to get a box of 100 for like $20. It's super cheap. And, I don't even charge the patient in a lot of cases because it's such a big, so effective for me, such a big thing that's made my surgeries successful post-op for these patients. I just throw it in. I mean, to me, it's kind of like, it's insurance, and that means something for me. I don't need to pass that cost on, but I know you probably could. And then what you do is you just inject this almost like an infiltration that you would do for a local anesthetic. It's just like an infiltration around the surgical site. It could be, again, it could be an endo, oral surgery, third molars, could be just simple implant placement number 14. You just like inject this stuff at the, dexamethasone at the conclusion of surgery into the vestibule, kind of like you would do an infiltration injection, and that's it. No prescriptions needed, no compliance from the patient. You're set to go for about the next 6 days. So what a wonderful way to, step up your game, essentially, from your local anesthetics to your antibiotics to your analgesics, and then finally your anti-inflammatories. I mean, to me, it's a no-brainer.
Yeah, that might be some of the best advice I've heard in a long time. Now, if you're doing something on the lower arch, would you still infiltrate it the same way, or you wouldn't give it as an IA block, would you? Or
No, there's no need to do that. There's no need to give it that deep. In fact, just into the general area of the infiltration is all you need to do. And so I keep mentioning the dose of 4 milligrams. There's some research at 8, and there's even some research at 10 or 12. So some people ask me, say, well, Jason, if I wanted to infiltrate a little bit around the 4 third molar areas, could I break up that dose into those areas? Absolutely. So maybe you step it up to 8 milligrams and you give 2 milligrams in each site. And wow, I mean, to me, if you can decrease that swelling response, and not impair healing, I mean, why wouldn't you want to do that?
yeah, because when I used to originally always think about anti-inflammatories, steroids, I always thought, well, that's going to decrease the body's response to heal. I'm trying to heal something. How's that going to relate? But the more I started learning about steroids' ability to reduce inflammation, and these inflammatory factors being a bigger problem of the healing than the actual pain or an infection, that's where I started really thinking, there's got to be more to this. I got to find out what other people are doing, and I know somebody's got this figured out better than me, so that's kind of what led to this, me trying to get a hold of somebody who actually knows what they're doing.
Well, yeah, no, the steroids has that connotation, right, or that stigma, perhaps. The patient, you say, I'm going to write you a prescription for a steroid. Well, that doesn't sound that good, but really it's an anti-inflammatory that has these great properties with almost no negative. And then you start to think to yourself, maybe it's your next question, which would be, who can't I give this to? Because it's so good, I want to give it to everybody, right? And there's only a few patients that you probably wouldn't give it to. And probably the biggest one, well, there's two in my mind. One is a pregnant female. And so you may not be doing a ton of dentistry on a pregnant female anyway. But the other one is probably the diabetic. And it might not even be the controlled diabetic. It might be sort of the ones that don't have the greatest control. So, and, they're out there with the way that it's such an insidious disease in our population right now. They're sort of out there. But that might be it. I mean, pregnancy, uncontrolled diabetes, and that's kind of it. That's the beautiful thing about this medication, as it's in the doses we're talking about, super safe, very little downside, and very few interactions that we really need to keep in mind.
I even had a case this last week where I was thinking, gosh, I ended up giving the gal a Medrol dose pack, and I thought, that was after a day or two of swelling that it was unexpected. But I was even thinking this last week, boy, there's got to be a better way to deal with this, and how can we prevent this on the front end? And that definitely sounds like that would be it. Now, tell me what you're thinking most dentists are doing wrong as it relates to pharmacology. I mean, I think most of us try to approach it properly, try to only do what's necessary, and try to keep it under control. But what's a misconception about maybe what a lot of dentists are prescribing that maybe they shouldn't be, or things they don't know about, or a lot of mistakes that you maybe are hearing about when you're lecturing? What's probably the biggest problem with, other than just overuse of opioids, which obviously everyone's aware about right now, but maybe besides that, or maybe including that, yeah, what's the biggest problem you see?
That was at the tip of my tongue, and you preempted me at that because you knew that was what I was going to say, which is interesting because I think we do have a tendency, and again, I don't think it's in a bad way. I think that a lot of prescribing of dentists, and because we hear so much about it, is really for the benefit of the. I mean, we're really trying to help these people. I mean, we have a less tolerant public. That's documented. The idea that patients don't want to be in pain, obviously, and they want to make sure that we take care of it. In fact, I had a friend the other day. He called me and he said, Jason, you won't believe what happened. I got a negative Google review. I got a 1-star Google review because my patient called me after a week to 10 days post-surgery, and he wanted a refill on his narcotic prescription, and I told him no. So he gave me a 1-star Google review. I said, oh my gosh, are we really getting to that point that patients are going to then start slamming us on the internet because, maybe they think we're not providing what they want? And I asked him what he did about it. He said, well, he said that he wasn't going to prescribe anything over the phone, but that he encouraged the patient to come in for a look because there's probably something else going on. And once they determined what was happening, they would prescribe accordingly. So it's not that he said no, it's just that he said, hey, there's something probably else going on here after 10 days that, just prescribing more narcotics is not the answer, which he was 100% right. But that was really interesting and kind of sad in the same breath. What are people doing wrong? I don't know if I would say that people are doing things wrong. What I think that people tend to want to do in their practices is they get comfortable doing certain things and they continue to do those things. Whereas, dentistry, we all have to be continuous learners. And that just means, the idea that what works great in your hands, well, I'm not trying to take anything out of your hands, but what if I could give you some things that maybe work better in your hands? Would you be open to those things? And that's the idea of the dexamethasone or the glucocorticoids, is that, maybe I'm not changing so much what you do, but maybe augmenting what you do to make it even better. That's a wonderful adjunct. I think that's a true pearl, is the idea of integrating dexamethasone into surgeries, implants, oral surgery, and then endodontic therapies as well. And then also, not being afraid to hit it hard, meaning like if you recognize that dental pain, and usually that's very short term. So the idea of really 24 to 48 hours should be the time you hit it the hardest, giving max doses of your NSAIDs and acetaminophen during that time frame, encouraging people to not do PRN dosing, but to do on-the-clock dosing. The idea of, you say, well, here's some ibuprofen and Tylenol. I want you to take it every 6 hours. Set your watch, which means set your phone or your alarm and get up in the middle of the night and take your dose. Don't take it as you need it, because we all know that once pain comes in, it's harder to deal with than if you take care of it on the front end. So, standardizing your procedures and just doing things a little bit better can make a huge difference. If you need narcotics, if that's what you think that the patient needs, well, then hit it hard. Hit it hardest for the first 24 to 48 hours, prescribe accordingly, and then back it off quickly. The idea that, we shouldn't be prescribing 25 or 30 tablets of Norco or Percocet, maybe like 10 to 12 maybe is your sweet spot, and then having patients reappoint if they're still having a problem. Then the idea of antibiotics is really understanding your antibiotics. Most first-line antibiotic prescriptions for dentists will include a beta-lactam, which means penicillin drugs. So that's penicillin or amoxicillin. Understanding how to give those drugs. Penicillin's a 4 time per day dosing. Amoxicillin's a 3 time per day dosing. And then understanding that, maybe adding augmentin into your regimen. Then understanding clindamycin. Clindamycin gets a bad rap. I mean, this idea of that it can really rip up your stomach. I got news for you. All antibiotics rip up your stomach. Clindamycin has gotten somewhat of a bad rap. And then understanding how to prescribe clindamycin. It's 150 to 300 milligrams given 3 times a day, not 4 times a day. And so that 4th dose that a lot of people prescribe is not needed. There's no pharmacokinetic reason to use it. You're just adding on to those potential GI upsets for those patients. And then realizing, of course, that patients will not fill and not take prescriptions the right way most of the time. So you're always moving towards this idea of, well, how can I simplify my prescriptions the most? Is it, should I give amoxicillin or penicillin that requires 3 or 4 doses during the day? Or can I get away with, azithromycin, Zithromax, which is 1 time per day dosing, or Levaquin, which is 1 time per day dosing? How to really minimize prescription errors by patients and actually getting them to take it. Again, not doing anything wrong. I mean, dentists do all the right things. Do the patients follow our instructions? Are we setting ourselves up for success and our patients up for success? So it's just, it's just realizing some of those minor pitfalls that can really stand in the way. But I think if I had to give you one tip, and maybe it's even a mnemonic, it's this idea of 2-4-24. And maybe even I'll extend the mnemonic to be 1-2-4-24. So the 2-4-24 thing says, well, I'll give 2 drugs, 4 doses for the first 24 hours. And so that's ibuprofen and Tylenol, 600 milligrams of ibuprofen and 500 to 1,000 of acetaminophen, 4 doses for the first 24 hours. Set your watch, take it on schedule, and then call me in a day or tomorrow and let me know what your pain level is, and maybe we can go down to PRN. If not, your pain level is still high, we'll do another 24 hours and look at it again. That 1-2-4-24, so it's the 2 drugs, 4 doses for the first 24 hours. That 1 becomes that 1 dose of dexamethasone. So for me, the real great postoperative regimen is 1 injection of 4 milligrams dexamethasone, and then the 2 drugs, 4 doses for the first 24 hours. So, standardizing things. And, I think dentists, we like cookbook style medicine, right? We like the idea that you tell me what to do and I'll do it. Well, patients kind of like that too. Tell them what to do and do it. And then make it sort of a pledge to them that if they do this, your experience has been that they're going to have great relief and great success.
Yeah, that's fantastic. I think everyone's looking for, let's just make things simple and let's make it predictable.
Yeah.
Yeah, no, I tell my patients if they don't take the drugs how I prescribe them, their implant's going to fail and they'll be in a lot of pain. Now, they may not necessarily be true, but I know that patients don't listen.
I love that idea.
Because, I tell my staff, I say the customer's always right, but the patient's always wrong because they don't do what you tell them. And they have a misconception of who should be telling who what to do, like you were saying. So if you can simplify that for them and tell them exactly what to do, and make it easy to do, they're a lot more apt to do that.
Yeah, I mean, there's actually there's a company called, and again, I don't know how you feel about in your podcast giving out company names, but there's a company that it's called Healthcare Logistics, and it's a website where you can go and buy those little individual pill bottles, maybe even put your practice name on it, and then you can actually give that out to your patient, and they would have enough ibuprofen and Tylenol for the next 24 hours or 48 hours, so that you made it even easier for the patient. They don't have to worry about picking up any medications. They leave with it in a little box that has your practice name on it, and they just follow the instructions. And that's that path to success that I keep mentioning. So there's all kinds of things that you can do with branding exercises and marketing of a practice to then sort of build in this idea that, we've got this system. We've set up this system for a great patient experience, and it starts preoperatively with your chlorhexidine and your antibiotics. And then after the fact, it's talking about your anti-inflammatories and your analgesics. And if I've used my local anesthetics, great. If I've used my Marcaine or my Articaine or whatever, maybe even for those first few hours, patients are feeling wonderful too. So really, it's that comprehensive approach. And some of it's what we're already doing. And there's no question that, this is review for a lot of dentists. But if there's a couple of pearls in there to streamline this thing, boy, I'm happy to provide that. So this is great.
Yeah, I love that. I think everyone wants to get down to the heart of the matter here and the real material. So what are your 3 best practices as it relates to pharmacology for oral surgery? And I know we've probably already touched on those, but what are your 3 take-home notes here?
Okay, so number 1 is dexamethasone. I think that integrating a glucocorticoid, whether it be dexamethasone as a pill, injection, or a Medrol dose pack, something like that is a wonderful thing that if you haven't tried it, you got to try it. I think that will make a huge difference. I'm just like you. Any practitioner, when I leave the office on a Friday afternoon, I would rather not. If I got to get a phone call from a patient, then so be it. But if I don't, that'd be great too. And those glucocorticoids really help me get comfortable patients that won't have problems after hours at the office. That's number 1, first and foremost. Number 2 is probably set your expectations for your patients correctly. I think that most dentists are good at this, and I know that implant surgeons for the most part are, because the key to success with implants in a lot of cases is following the steps. You have a kit. Which drills go first and second and third, and then ultimately which implant to use. And if you plan it out right, you really have a great chance to get a positive outcome. But this is the same thing with setting the patients up from a pharmacologic standpoint as well. Understanding who's in the chair, understanding where your risk factors are. We understand the dental risk factors, but what about the patient factors that could impact success? Are they healthy? Are they not healthy? Are they controlled? Are they not controlled? Do they have any allergies or intolerances? So I've almost like that same kind of plan that you have for your implant. What size I'm going to use. How long I need to have it. I have a plan from a pharmacologic standpoint too. I understand what I'm going to be prescribing up front, what I'm going to use during the procedure, and then what I'm going to give the patient afterwards to have them be successful. So for me, that's really about a pharmacologic plan, and it's individualized for every patient because everybody's different that walks through your door. And then lastly, and probably least sexy of my tips is just get back to basics. You know what I mean? Stay within your swim lane, so to speak. Stay within the guardrails. It doesn't mean you change a ton of things in your practice. It just means you're really getting back to basics, which means, focusing on ibuprofen and Tylenol as first-line analgesics, recognizing that pain from dentistry is inflammation and probably short-term, and hitting it hard for that first 24 to 48 hours and trying to back it off quickly. Exposure to antibiotics is a big thing, minimizing that. And then just realizing, again, I can't tell you how many times I've spoken to dentists, and I'll say to them, what's the max dose of lidocaine, or how many articaine carpules can you give? And they just don't know those answers. So understand the basics of pharmacology. And again, that first drug that every dentist has got to know, because we use it so much, is local anesthesia. Understanding, a little bit about max dosages, about right drug, right patient. And one tip I sometimes give for patients, for doctors, is there's something called the rule of 25. Now, this is from a colleague, a mentor, and a friend, Elliot Hirsch from the University of Pennsylvania. He says rule of 25 is you give 1 carpule of any local anesthetic for every 25 pounds of body weight. So that's a quick and dirty way to understand max doses of local anesthetics. So for a 50-pound person, right, that's 6 carpules. 6 carpules of anything, and that gets you to around 75 to 85% of the maximum. And then, knowing your half-lives and things like that, what you can do. Because I can't tell you, I've been involved with some cases where one guy gave 27 carpules of lidocaine, one guy gave 21 carpules of marcaine, another person gave 14 carpules of lidocaine with 1 to 50,000 epi. I mean, just get back to the basics. Those numbers sound incredible, but yet they're true. And so again, just get back to basics.
That's a lot of juice.
That is a lot of juice. A lot of volume. That is a lot of volume.
I'd be a little worried about that, but hopefully everybody made it out okay.
Yeah, that wasn't always the case. That's the scary part, is that, these are drugs that we use every single day and have a tremendous safety margin, but yet when you forget that stuff, wow, there can be some bad outcomes.
Yeah, and especially for lightweight, compromised, or children, that that can be real scary.
Oh, absolutely.
Okay, last question here. Who else do you think I should interview as it relates to implant dentistry? Who's in your circle of knowledge base that you think would be a good contact for me?
Well, I think you hit the big one. I mean, when I think about my own career and the people that I really enjoyed learning from and listening to, and always follow what they're doing, I think Arun Garg you've already interviewed him, so he's at the top of my list. I mean, just a really visionary guy. And so if for the listeners today, if they haven't heard Dr. Garg or looked into him and see the kind of courses he does, that's a wonderful place to start. Another guy that, if I've sort of piqued your pharmacologic interest today, another guy that I think is just a fabulous resource is a gentleman named Dr. Mark Donaldson. He is an actual pharmacologist. So for me, I'm a dentist, and pharmacology is just a hobby or a passion. But I mean, that's this Dr. Mark Donaldson's thing. I mean, he is a dental pharmacologist and does just an incredible amount of lecturing around these topics and many more. So he's a real good guy. And then from the prosthetic side of things, a gentleman named Dr. Nicholas Conti, who's a prosthodontist in Delaware. He does a lot of things with the restoration of implants in terms of impressioning techniques, the CAD/CAM side of things, and how to integrate digital solutions. And one of the things I know that he's looking at, some of his research and some of his focus is around, what is the right way to place a final restoration? Is it cement retained? Is it screw retained? And then further on that idea is that if you had to cement it, what's the ideal implant cement? So I know he's involved in that right now, and there's a lot of controversy around that, and so maybe that's a good topic for your next one.
Yeah, no, those are definitely important topics for sure. I think, I've already had a couple interviews about that, and I need to revisit that more because putting the implants only half the story. People want teeth, so how to give them the best set of teeth is always the end goal. So can't underemphasize that.
Yeah, I mean, it's a fascinating topic with the peri-implantitis thing going on right now, and the move and the swing towards screw retained. I mean, there's a lot of great information out there.
Kind of goes back with coming back to basics. I think we're coming full circle to why are we really doing what we're doing with cementing and screw retaining. We've been through a whole cycle of it. We're seeing some failures, and hopefully as a whole, we're all getting back to basics on how are we actually attaching teeth to these implants, because that does make a difference. So, lastly, to finish up here, how can people get a hold of you if someone says, I really like what this guy has to offer, this Dr. Goodchild, seems like he's got his act together. Where can people see you? Where are you lecturing? If someone wants to catch you out on the circuit or the lecture trails, or someone wants to get a hold of you and says, I have a specific question for you. I thought the podcast was great, but maybe I forgot some good questions, and they've got a burning desire they want to reach out to you. Kind of give me where are you going to be available here in the next year or two?
Okay, sounds good. I work a little bit with Dr. Garg, and I've been helping him with some of the pharmacology piece, and so that he's a real good guy to work with. But I also work with some of the dental schools. I work with University of Washington, Oregon Health Sciences, Virginia Commonwealth, University of British Columbia, and we do a lot of pharmacology courses and then pain control courses, things like nitrous or sedation. So kind of a wide range of courses around helping dentists with this idea of pain control and how to integrate pharmacology. So those schools, if you just Googled their continuing education departments, you can find out some of the courses that we're offering. And then, on the Dentsply side of things, I speak for them. And so it might be easier if anybody would like to hear anything more about that or where I might be, just to email me. My email is pretty simple. It's just Dr. So Dr. Goodchild at yahoo.com. So that's DrGoodchild at yahoo.com. And just like most of us, I'm pretty responsive on email because it comes right to my phone. And it seems like we check that too many times a day. So I'm sure I can get back to the folks as quickly as they need it.
Yeah, because depending where you're at or what people are wanting to hear, you're probably doing something different at all times. So there may be something that's got somebody's interest somewhere along the way. And so you're either going to be at a university or at some sort of sponsored event at some point, geographically near somebody at some point. So that sounds great.
Yeah, I'm happy to help. And, I quoted some research tonight, and if anybody's looking for some of those primary sources, just let me know, and I'm happy to provide. I love giving people stuff to chew on a little bit. I can tell you the results of the study, but it might be interesting to hear about why they did it or how they came up with it or how they designed it so that maybe it matches what you're doing clinically.
Yeah, that's great. You got to have a reason for what you're doing, and definitely we always want to look to science first. So, appreciate your time tonight. I think it's been a very great exposure to what we need to kind of further refine with our pharmacology. So thank you for your time, and look to hear from you again. Maybe if I get further down the line with this and want to come back and circle in a little deeper on these topics, we'll have you back on.
Anytime, Philip. It's been a pleasure. Thank you.
Okay, thanks so much.